Good evening, everyone. Thank you, Neeraj sir. It was a wonderful section. So, going to my title, I'm going to present an interesting case, pancytopenia with a twist, from fever to firestorm. So, my patient is a 25-year-old female. She's an IT professional at Trichy with no known comorbidities. So, she presented with complaints of fever with chills since 2 weeks, fatigue and headache since 2 weeks, loose stools and vomiting since 3 days. So the fever was intermittent, low grade in nature, which over the last 3 days become high grade, associated with chills and rigors. So she also had severe fatigue, which restricted her daily routine activities, just dull aching and bifrontal. It was not associated with photophobia or phonophobia. So the loose stools, it was 3 to 4 times per day, watery in consistency, not foul smelling, occasionally associated with mucus, not blood tinged, vomiting 2 to 3 episodes per day, predominantly postprandial, non-bilious, non-projectile, containing food particles, associated with nausea, and there was loss of appetite also. So there was no history of cough, breathlessness, chest pain, palpitations. There was no altered sensorium, dysuria, reduced urine output, hematuria. There was no history of any rashes. There was no significant recent travel history. But there is history of food consumption from outside. So for the same issues, she went to one local hospital and she already took 2 courses of oral antibiotics. Since her sister is a staff in AIMS, when her symptoms got worsened, brought her here for further evaluation and management. So when she sir, Amrita, yes sir. So yes, Amrita. So when she presented, she was on day 2 of cap doxycycline. So going to the examination part, she was conscious, oriented, lethargic, and dehydrated. And vitals on arrival, her pulse rate was 102 per minute, just regular and low volume. BP 90 over 60 millimeters of mercury in right upper limb supine position. Respiratory rate was 20, temperature of 101 degree Fahrenheit, and saturation was 98% in room air. And she had pallor. There was no iterus, clubbing, cyanosis, pedal edema, or lymphadenopathy. And on systemic examination, the oral cavity was unremarkable. Per abdomen examination, respiratory system, CVS, nervous system examination, everything was fine. So the possible differential diagnosis includes enteric fever, malaria, infectious mononucleosis, rickettsial infections, leptospirosis, and it can be an autoimmune cause, probably SLE. So she was admitted and we started on injection ceftriaxone and continued cap doxycycline along with other supportive measures. So we got the initial blood investigations in which she had anemia, HB of 9.5, total count was 2000, and she also had thrombocytopenia, platelet was 57,000, CRP was 257, and SGOT was on the higher side 135, and mild hyponatremia. So now the differential diagnosis includes HLH and leukemia also, because of this pancytopenia and elevated inflammatory markers. So we did one peripheral smear. It was showing no parasite or any inclusion bodies. There was no atypical cells or blast cells, and the platelets were singly scattered with a few large forms. And the absolute reticulocyte count was in the lower side, and LDH was elevated, 1712. And her iron was on the lower side, 25.6, and ferritin was elevated, 3828. So as part of the workup, we sent salmonella, it was negative, malarial antigen, peripheral smear for malarial parasite was negative, dengue was negative, lepto, CMV and EBV IgM negative, and HIV, anti-HBsAg, anti-HCV, everything was negative. And we suspected HLH because of that elevated inflammatory markers, pancytopenia, and low ESR. And This is the HLS 2024 criteria. So in this criteria there is fever should be more than 38.5 degrees Celsius. Uh, should be have should have splenomegaly more than 2 centimeter below the costal margin, cytopenias, then low fibrinogen level, hypertriglyceridemia, then hyperfertinemia, and there should be hemophagocytosis or and elevated soluble CD25. So for the diagnosis, it should fulfill more than or equal to 5 of the following criteria. So for my patient, we did the HLH workup. So the fibrinogen was on the lower side, 139. Triglycerides were elevated. Ferritin was high. AST was also elevated. And we did one USG abdomen. There was no organomegaly. So my patient had fever more than 38.5. There was pancytopenia. And there was hypofibrinogenemia or hypertriglyceridemia. And the ferritin was on the higher side. So as per the protocol, we started on injection DEXA 8 mg per BD, 8 mg BD. As per the protocol, 10 mg per meter square per day. And we planned for etoposide if the patient clinically further worsens. And we did one bone marrow in view of pancytopenia and for the confirmation of HLH. And we got some unusual cells. These are the hemophagocytes. The macrophages engulf. We can see the RBCs, erythroblasts inside the activated macrophages. So these are hemophagocytes. And we calculate the H score also. So in the H score, this I got from the Medcal. It's an online application for calculating the H score. So with this with the help of Medcal, I calculate the H score. The patient had immunosuppression and temperatures. There was no organomegaly, and there was pancytopenia. Ferritin was elevated. So the total H score was 230 with 96 to 98 possibility of HLH. And on day 2 of admission, she had worsening of hypotension. Her BP dropped to 80 over 60, which didn't improve with the IV fluid. So we started on inotrope support. And she had continuous high-grade fever spikes also. So, and her cell counts and inflammatory markers were also worsened. Her total count initially was 2000. It dropped to 1660. Platelets from 57,000 to 49,000. CRP also worsened to 338. And we checked the procalcitonin, it was 18. And subsequently, the blood culture also provisionally told there is one gram-negative bacilli. So these are the possible gram-negative bacilli which can cause this type of symptoms. It includes Escherichia coli, Salmonella, Shigella, Klebsiella, Pseudomonas, Yersinia, Vibrio cholerae, Brucella, Campylobacter jejuni, then Aeromonas species. So in high clinical suspicion of enteric fever, and since the patient is also clinically worsening, we escalate the antibiotics from injection ceftriaxone to injection meropenem. And we changed doxycycline to azithromycin. So we started as 1 gram stat, then 500 mg OD. And her stool culture came out to be negative. Since the patient is already on 8 mg BD of DEXA and she was clinically worsening, we increased the dose to 8 mg Q6 early. And this is a journal I got from NEGM. It was published on January 12th of 1984. The title of the study is Reduction of Mortality in Chloramphenicol treated severe typhoid fever by high-dose dexamethasone. So, as per this literature, my patient weighs around 50 kg. So, as per the literature, she should get around DEXA of 3 mg per kg followed by 1 mg per kg Q6 hourly for 48 hours. So it will come around 150 mg stat followed by 50 mg Q6 hourly for 48 hours for 2 days. But we just continued with the 8 mg Q6 hourly because patient was clinically improving. And we got the Vidal test report also. It was showing Salmonella typhi O of less than 1 is to 20 dilution, and Salmonella typhi H was more 1 is to 160 dilution, and both paratyphi AH and BH was negative. Finally, we got the blood culture report. So it was a Salmonella typhi, resistant to ciprofloxacin and sensitive to ceftriaxone. But we continued with injection meropenem and tabazithromycin because literatures are showing in severe Salmonella or enteric infection, we have to continue meropenem with azithromycin. Meropenem in a dose of 1 to 2 gram Q8 hourly, and azithromycin 1 gram stat followed by 500 mg OD. Subsequently, her cell counts, inflammatory markers, and liver enzymes started improving, and the patient also got symptomatically better. So initially, her ferritin was around 3,500, but at that time of discharge, it improved to 74. And the total count initially it was 2,000. At the time of discharge, it became normal, more than 4,000, and the platelet also improved more than 3 lakhs. And slowly, the IV steroids were tapered to oral steroids, and it was stopped over 2 weeks. And after 10 days of injection meropenem, we escalate the antibiotics to injection ceftriaxone 2 gram OD for 4 more days, and we discharge the patient. So going to some few slides regarding the discussion part. Salmonella with secondary HLH. Enteric fever with secondary HLH. So going to the antimicrobial therapy for enteric fever. So here, if there is a drug susceptible typhoid, we can go for fluoroquinolones. The cure rate is around approximately 98% with relapse and fecal carriage less than 2%. Because of widespread resistance in areas like India, Nepal, South Asia, and parts of Africa, the fluoroquinolones should not be used as an empirical in these regions. So the empiric therapy includes the first line options are ceftriaxone or azithromycin. And if you are suspecting a ceftriaxone resistant typhoid, for example, if there is a travel from Pakistan, or if there is a multi-drug resistant circulation, or if there is a treatment failure, we have to go for carbapenem, meropenem, or imipenem. So these are the antibiotics of choice with dosage and duration, in which the first line is ceftriaxone 2 gram IV once or twice daily for 10 to 14 days, and azithromycin 1 gram once daily, then 500 mg OD or 1 gram OD for 5 to 7 days. Antibiotics like chloramphenicol, amoxicillins, Bactrim DS are limited useful now because of the multi-drug resistance of the organism. So going to the viral test. So O antigen TO, it's a somatic antigen. It appears early and short-lived, which denotes active infection. Then H antigen, it's a flagellar antigen, appears later and persists longer, denotes past infection or any previous history of immunization. And going to the interpretation, there should be a 4-fold rise in the titer over 7 to 10 days is diagnostic. And the somatic antigen or flagellar antigen more than or equal to 1 is to 160 dilution is supportive, but it is not confirmatory. So false positives will be seen in if any prior infection or any history of recent vaccination, and the false negatives are seen in early testing or if there are any prior antibiotic administration. So in my patient, initially her Salmonella typhi H titer value was 1 in 160. So we repeated the viral test after 10 days, and after 10 days the Salmonella typhi H titer was more than 1 is to 640 dilution. So it's 4-fold rise. So it is confirmatory. And how rare is HLH secondary to Salmonella? So the commonest organism are EBV around 30 to 40%, then CMV, malaria, dengue, influenza, COVID 20 to 30%, Then salmonella is seen in 0.1 to 0.5 percentage as a trigger for secondary HLH. So going to the HLH, it's a syndrome because of excessive inflammation and tissue damage caused by uncontrolled immune activation. The HLH is broadly classified into primary, which is genetic, and secondary because of reactive. And the primary can be due to familial HLH and because of some immune deficiency syndromes like Viscotalrich syndrome, Griscelli syndrome, or it can be severe combined immunodeficiency. And the secondary causes includes if there is an infective trigger, malignancy, or autoimmune. The common secondary causes for HLH includes viral causes like herpesvirus, HIV, other viruses like adenovirus, hepatitis, parvovirus, influenza, measles, etc. Then going to the bacterial causes include Staphylococcus aureus, Campylobacter, Fusobacterium, Mycoplasma, Chlamydia, etc., Salmonella. Then parasitic Leishmania, Plasmodium, Toxoplasma, Strongyloids, Spirochetes. Then fungal includes Candida, Cryptococcus, Pneumocystis, etc. So going to the malignancy as a secondary trigger for HLH, the commonest ones are T cell or NK cell lymphoma or leukemia, then peripheral T cell lymphoma, anaplastic T cell lymphoma, acute leukemias, then solid tumors includes hepatocellular carcinoma, prostate carcinoma, lung carcinoma. Then the HLH secondary to an autoimmune condition is called MAS, macrophage activation syndrome. So the autoimmune diseases can be a secondary cause for HLH includes systemic juvenile idiopathic arthritis, Still's disease, SLE, Kawasaki disease, and rheumatoid arthritis. So going to the pathogenesis of HLH, whenever there is an initial trigger in a susceptible patient, like infection, malignancy, autoimmune, or if there is any genetic defect, there will be a defective cytotoxic function. There will be an impaired perforin granzyme pathway, and which in turn cause the failure to kill target cells. So there will be persistent antigen, which cause continuous immune stimulation, and there will be uncontrolled immune activation, cause excessive activation, proliferation of T lymphocytes and macrophages, and this will cause an cytokine storm. There will be massive release of inflammatory proteins like interferon gamma, TNF alpha, and other interleukins, and there will be macrophage activation, which cause hemophagocytosis, which in turn cause tissue infiltration, and organ damage includes hepatitis, splenomegaly, seizures, encephalopathy, pancytopenia. So this was the firestorm, which I mentioned in my title of that interesting case, Fever to Firestorm. So the management includes induction therapy with etoposide plus dexamethasone for 8 weeks. Etoposide we start with 150 mg per meter square, and over in the first 1 to 2 weeks twice daily, then from 3 to 8 weeks once weekly, and there is creatine clearance for this creatine clearance is there for this etoposide. And next drug, dexamethasone. We'll start with a dose of 10 mg per meter square per day for the first 2 weeks. Then in the third and fourth week, 5 mg per meter square. Then 5th to 6th week, 2.5. In the 7th week, 1.25. Then the 8th week will taper to 0. Then the third drug, cyclosporin. It's not routinely used for management of HLH. The dose is 6 mg per kg per day, and the target trough level is 200 microgram per liter. And the cyclosporin is having a risk of posterior reversal encephalopathy syndrome, so that's why it's not routinely used. And we can consider in severe patients with having strict blood pressure control, and there should be close neurological monitoring. So the take-home messages are in worsening sepsis with the cytopenias, we have to think beyond infection alone, and the early recognition and parallel treatment of both the trigger and hyperinflammation can be life-saving. And there should be timely escalation of antibiotics and immunosuppression, which can improve the outcome of the patient. Thank you.